Hiya, my name's Ella. I'm one of the scientists at the Cardiff Poisons Unit, and I'm just going to talk through the study and some of the findings. So the rationale for this study, so Lawrence and I attended the AWTTC Best Practice Day back in 2023, and Harriet gave a great presentation with Sheridan Court about some of the issues surrounding polypharmacy, especially in older patients, and maybe some of the issues surrounding the use of monitored dosage systems. I sort of recognised that in the Poisons Information Service, we receive inquiries about older patients who've taken more than they should have from their dosage box. So we saw this as an opportunity for perhaps a novel study crossing multiple organisations. So the objective for this was just to analyse the data from inquiries to the Poisons Information Service to see if there were any trends in demographics, what types of medications were involved, whether patients became symptomatic, the circumstances regarding or surrounding the incident, and what we advised as a service. So this is a screenshot from our UK Poisons Information Database where we enter all the information about our calls. Um, and so we carried out a retrospective review of all the calls from the 1st of Jan 2017 to the 31st of December 2022. So this is a 5-year study period. We looked at all calls involving patients aged 65 and over, with the circumstances coded as therapeutic error or medical error, and we filtered for those just involving the use of an MDS. So, just sort of definitions wise, the UK Poisons Information Database defines therapeutic error as an incident. As incidents occurring as a result of the patient themselves or a friend or family member making a mistake during administration, whereas medical error are incidents occurring as a result of discrepancy by a healthcare professional, and we did include care workers in this as well. And just to note, so the MPIS is primarily contacted about incidents of overdose, as opposed to other sort of medication errors. So to make it a bit easier, we sort of came up with 7 main categories for the errors. So the first one was just missing medications. So carers or family members have gone in, the medications are gone, but they're not entirely sure what's happened. Error during patient self-administration, error during care worker administration, error during family member administration, a suspected dispensing error, a device error, or just it didn't come under any category. So in terms of the results, we received 394 inquiries regarding 393 patients. Inquiries were primarily GPs with nearly 42%, followed by NHS 111 making up 30%, and then ambulances, hospitals, and community pharmacists in smaller numbers. The majority of our calls came from England, so 87%, followed by 6.1% in Wales, 5.9% in Scotland, and then smaller numbers in other regions of the UK and Ireland. Gender-wise, so of the 393 patients, 266 of these were female, so that's nearly 68%. This was significant with a p-value of 0.0156. This is the age categories then. So you can see there's a little bit of a sort of peak between the 80 to 89, and the mean age was 81.2. Cognitive impairment was reported in 32.3% of patients. This isn't something that we routinely collect information on, and I'll discuss this in the limitations a bit later. Location-wise, so nearly 95% of these occurred at home, as you might expect, then smaller numbers in care homes, and then 2 cases from a prison and 1 in hospital. So in terms of the circumstances for incidents, so nearly 60% of these were error during patient self-administration. Almost 22% were just medications missing, not entirely sure. 10% are a suspected dispensing error. So this is either actually in the pharmacy or during delivery to homes, and also upon discharge from hospital. Error during care worker administration was about 6%, and then 2% for family member administration. In 2 cases, they had like an automated MDS device, I think, which had malfunctioned, and then it's not clear in the other case. In terms of medications, there were 270 different medications reported. The maximum number of different medications in a single ingestion was 12, and then 27.8% of patients ingested 5 or more different medications in a single overdose. So apologies, this might be a little bit small, but I've put the top 20 medications reported to be taken in overdose in a table. So you can see bisoprolol is the most common one, reported 74 times in overdose. So there are a couple of medications on there that are concerning for us. So there's a couple that are known to cause cardiotoxicity in overdose, so bisoprolol being one, and then amlodipine and ramipril we would be concerned about. There are also a few on there which sort of antiplatelet and anticoagulant medications that may increase the risk of bleeding as well in older patients. So in terms of the features of toxicity or symptoms, 311 out of 393 were asymptomatic, which is good. Where features were reported, these included things like drowsiness, dizziness, confusion, and then in smaller numbers, things like gastrointestinal upset, headache, and then 2 cases of bradycardia, 2 cases of tachycardia. So all in all, patients were fairly well following the overdose at the time of the call. And then the poison severity score. So this is just a score that we assign at the time of the call, depending on the symptoms reported. So 313 had a PSS of none, 57 had a PSS of minor, 4 had a PSS of moderate, 2 was severe, and then it was not known in 17. But yeah, no fatal cases were reported at the time of the call. So what did we advise? So for 132 patients, we said sort of fine to continue home care, check with prescriber with regards to next dosing, and watch out for sort of worsening symptoms. But for 200 patients, so that's more than half of our cohort, we advise them to attend A&E. With 71% of patients, we advise referred to GP. So 311 out of the 393 patients were asymptomatic with a poison severity score of none. So of these 311 patients, 146 or 47% were recommended assessment in A&E. And this obviously sounds like a high number considering the fact that they were well. This is an excerpt from Talkspace. I think this is from the bisoprolol entry. So this is where we sort of get our management advice from. And you can see here, so our sort of criteria for referral for a medical assessment includes elderly patients or patients with significant cardiac history or asthma who've taken anything more than their therapeutic dose. So even if it's just one extra tablet, if the patient is 65 or over, we would refer them to A&E due to increased risk. There's also the bottom statement there, so all patients who've exceeded their prescribed daily dose of 2 or more cardiotoxic agents. So if they've had one extra tablet of both bisoprolol and ramipril, for example, we would be sending them in. So key points. Despite the use of monitor dosage systems, and they do have their place, but older patients, our study sort of shows that older patients do continue to be at risk of medication errors, including accidental overdose, despite their use. Cases reported mainly occurred at home, as you might expect. Medications commonly reported to be taken in accidental overdose include high-risk medications such as drugs that affect the cardiovascular system and those that increase bleeding risk. The most common circumstance is error during patient self-administration. And over half of the patients in the study were referred to A&E for assessment. Obviously, we're not going to go too much into this, but referring older patients or older patients attending hospital comes with its own risks. There are a few limitations for this study. So poison center data is retrospective. We don't routinely collect data about whether a patient has an MDS or whether they are cognitively impaired. And data collection relies on the quality of the inquiry log. So the amount of detail might differ depending on who's taken the call or the amount of information that's provided by the caller. And just to reiterate, this is reported data, not actual incidence data. So the Poisons Information Service won't be made aware of every case. So it's possibly an underrepresentation of the amount of incidents. And there's also a lack of outcome data as well. So, we're saying over half the patients in our study were referred to A&E, but we haven't got the sort of capacity as a service to be following up all of these calls to check whether they did attend A&E or not, and whether or not they did to go on to develop any symptoms after the call.
Future work includes a prospective study to allow for more accurate data, predetermined questions for SBIs to ask at the time of the call, and mandatory follow-up. Further multi-organisation collaboration to increase medicine safety and to raise awareness of potential safety risks of dispensing MDS for some individuals. Production of AWTTC or Wales guidance on adherence aids with the Community Pharmacy Wales. This aims to support the implementation of appropriate adherence aids. The World Health Organization stated that approximately 50% of people do not take their medication as prescribed. This can be for a number of reasons, intentional or non-intentional. However, non-adherence can result in harm to the individual and is really important to address, as highlighted by the results of this study. One study also found that non-adherent adults over 50 years old have an increased risk of hospitalization of 17%. In addition to the risk of harm from the non-adherence to medication, there is also the cost to the NHS of wasted medication, which is around 300 million annually, but this cost goes up to 800 million when included managing complications from non-adherence, such as side effects. Additionally, there is the environmental impact to consider, with this wasted medication resulting in 740,000 tonnes of CO2e in greenhouse gas emissions annually. This is equivalent to 171 million car miles, which would be over 6,000 trips around the world. This study highlights the importance of individualised adherence aids that are appropriate to meet the requirements of the individual. MDS are not the universal solution. Regular medication reviews and assessment for adherence aid support is important. When it comes to adherence reviews, one of the important things to note is the Equality Act 2010. This requires a dispensing contractor to assess individuals with disabilities and make reasonable adjustments to support adherence. The community pharmacists conduct reviews and, where appropriate, make reasonable adjustments to support patients to access their medication. The adjustment must be reasonable for both the pharmacy and the individual and may result in the initiation of an MDS or another appropriate adherence aid. Community pharmacies are not required to dispense MDS because they have been directed by another healthcare professional, but it is important that we work together for the best outcome for the patient, and health professionals and social care should work with community pharmacies to help highlight concerns and find reasonable adjustments. It is important that this is done in line with medication reviews to maximise benefit of the medication and reduce risk, and if appropriate, reduce inappropriate polypharmacy. This slide highlights the benefits and risks of MDS use. There are benefits associated with the use of MDS, and for some individuals they can be helpful to support them to take their medication by making them more accessible and support them to be independent. However, there are also some risks associated with the use of MDS, and it is important to ensure that the use of MDS is appropriate for the individual. Some of the risks are that the use of the MDS may result in less knowledge of what medication the individual takes. They are not suitable for those with severe memory impairment, as highlighted in this study. Not all medication are suitable for MDS, which can result in individuals using two systems, original packs and the MDS, and this can result in errors. In addition to MDS, there are various aids available to support medication adherence. As part of a medication review, it's important to discuss with the individual what type of support they may need to ensure that the adjustment can be tailored to meet their needs. For example, electronic alerts as reminders such as Alexa or phone alarms to remind the individual to take their medication. Grip tablets for those who may need support due to dexterity. There are many supports available, and this research has highlighted that there is importance in tailored support to meet the needs of the individual. As mentioned earlier, we're working with AWTTC and All Wales guidance on adherence aids. As well as medication adherence, a general medication review is helpful to ensure that the appropriateness of medication and maximise benefit of them. There are many resources available to support medication reviews, and I've included a few. AWMSG Polypharmacy Guide. This includes polypharmacy review and a small section on adherence. There is also the Scottish Polypharmacy Guide, which includes the 7 steps in conducting medication review. The Health Innovation Network have done a campaign on polypharmacy, and they have some useful resources for patients, such as printouts to help patients note down any side effects when stopping medication. NHS England have produced a helpful guide for healthcare professionals and care workers to support reviews and implementing appropriate adherence aids. This includes a list of different adherence aids available. Community Pharmacy Wales also have some useful resources on adherence aids, as well as SBS, which is particularly helpful for reviewing medication appropriateness for MDS.